So this is the SMN1 gene, the gene that we need, the SMN protein, and the SMN2 gene, as you can see, are just differs from a single base from SMN1 gene. And so the strategies that we will have to adopt is either to replace this gene, either to act on the SMN2 gene. So we must understand that, one more time, this is a moving target, and it has moved very fast over the last 10 years. The first multidisciplinary management came in 2007, and the second one 10 years later, and then came new treatments. And I just wrote with the S because there are nowadays 3 drugs that are approved by the FDA and by EMA. And then the question that come today is which one and when. Which one? It's still definitely an open question, but when is an easy question. It's as soon as possible. And if we want to achieve as soon as possible, there are 2 strategies. The first one is disease awareness, and this is something that we're just doing today, so it's great. But the most efficient is certainly newborn screening, and this is certainly the most efficient. So since 2018, we conduct newborn screening and early treatment. And now, of course, this open the way to new management, because we see new kind of patients. Before going into the drugs, I want to emphasize multidisciplinary management is super important, and standard of care is super important. It is just impossible to treat SMA patients with just drugs. We need to be a team. We need to have the pulmonologist on board, the orthopedist on board. Otherwise, it's just impossible to treat these patients. Let's remind that we have adults in the community who have babies, for instance, like this lady with SMA type 1C, and these other ladies and in therapy. It's not because of nusinersen, it's not because of risdiplam. These patients have survived over years because of standard of care and because of multidisciplinary management. So we must continue provide our patients more than ever with this standard of care if we want these drugs to be as efficient as they called. So the first strategy would be to act on the SMN2 gene, and to act on this SMN2 gene, we can use oligoantisense, that's the nusinersen or Spinraza, or small molecules, and that's the risdiplam and branaplam. And we can also bring a new gene, bring a new copy using a virus, which is called the gene therapy, and today it's approved in Europe under the name of onazomnogen abepavlovec. We can also try to work on another target, on another tissue, on the muscle, for instance. And when we speak about add-on therapy, we think more and more about moving to other targets, other tissues. So let's go with the first drugs that was approved, the nusinersen. Today, we have quite a big bunch of data for nusinersen from type 1 to adults and to pre-symptomatic patients. So the first study for the phase 3 studies in these patients was a double-blind randomized placebo-controlled study, which means that we had this terrible disease of patients who died before the age of 1 year, and we randomized them, and we were blind to know if they had the drug or not. And the study has had to stop earlier because the differences between the patients who were treated and patients who were untreated was such that it was unethical to continue. This being said, this difference was much more clear in patients with a short disease duration. And that was the first evidence that treating early is more efficient than treated late. What we've learned from this treatment is that the motor response in these patients is quite heterogeneous, and that you may have patients with a very high and very good response and patients with a much poorer response. So this is actually a patient of the trial, as you can see, is able now to move before being injected. He has just some distal upper limb movement, and that's how he was at the end of the trial, able to roll over, and this is something that we had never seen before. This is one of the last video I had of this young man. He is not working today, but he does his best. He's doing his utmost. And today there are very, very few patients who have been treated after the symptoms who are actually workers. I think that it's very important for us to emphasize to parents and to manage expectation. SMA type 1 patients who have been treated after the symptoms, today it's really exceptional to have a worker. If they're treated before, that's another story, but after the symptoms, it's really, really rare. So what happens now to these patients? It depends. It depends when actually they've been treated. If they've been treated before the age of 5 months and a half, so with a shorter disease duration, they are doing much better than if they've been treated after the age of 5 months and a half, or if they've been treated after the age of 14 months. There is no matter of comparison. And of course, patients who have not been treated are doing much worse. So now we have more than 3 years of follow-up on these patients. This is even a longer follow-up, 1,538 days, which means nearly more than 4 years. And as you can see, well, these patients are not regressing, but we reach...
у них состояние не ухудшается.
Well, I hear someone speaking Russian. Is it possible to mute? Thank you.
Русский перевод. Можно ли отключить звук, чтобы мы не шли оба экрана?
As I told you, if we look at the motor function, not the scales, but the motor function, sitting or walking, the proportion of workers with assistance. Well, I'm sorry, but I hear the translation. Is it possible to mute it for me? But because it's very difficult to... Thank you. So regarding the walking with assistance,
Если мы говорим про возможность ходить даже с помощью, пропорция ходящих пациентов малая, и важно, чтобы пациентов начали лечить рано. Вот наше исследование. Это пациенты, которых начали лечить поздно, позже 7 месяцев. Именно даже у этих пациентов есть прогресс. Есть много данных у пациентов первого типа. Это исследование, опубликованное в Medical Journal в 2015 году. Посмотрите на этого ребенка. У него второй тип СМА. Он сейчас может встать на ноги. Также он может ходить. То есть в сильном проявлении второго типа СМА ребенок может начать ходить. И мы, в принципе, ожидаем, что ребенок сможет ходить со вторым типом. И здесь не о том речь, что бывает тип второй сильный или слабый. Здесь речь идет о том, насколько рано вы начали лечение. Посмотрите к возрасту 3,5 лет. Вы видите, насколько лучше будет таких пациентов. Сейчас у нас есть данные про взрослых пациентов. Они были недавно опубликованы. Здесь видно на графике 10 месяцев, 14 месяцев. И мы видим прогресс у этих пациентов. В итоге есть положительная тенденция у этих пациентов. Через 6, 14 и 10 месяцев мы провели исследование. Была группа плацебо тоже, но прогресс ощутим. Эта дама не принимала участие в этом исследовании. Это дама из Польши. Она сказала мне, а ей 49 лет, она рассказала, что она любит рисовать, но она потеряла возможность рисовать, и потеря такой способности это для нее гораздо хуже, чем потерять способность ходить. Для передвижения она может использовать кресло, но если она не может больше рисовать, это значит, она не может общаться с миром. И она ожидала простую вещь – восстановить свою возможность рисовать. И это ясно. Если бы она сказала «я хочу ходить», это ожидание нерациональное, невыполнимое. Если она хотела самостоятельно есть, это тоже тяжело достижимо. Но восстановить возможность...
pencil and to start painting. This is something that was feasible, and she did it actually. And the first thing she did was to start painting me and my team, illustrating the different approaches. That's Spinraza, that's the gene therapy, and that's the sunfish and firefish trials. And that's also the anti-myostatin drugs that work on the muscle. That's all of the painting of this lady. So that was for nusinersen. As you've seen, we have data in type 1, in type 2, and in adults. What about gene therapy? So the first trial of gene therapy was published in 2017, and there was 2 cohorts of patients, one with very low dose, and this one with very high dose, with a much higher dose, 3 times more actually. And as you can see, the response on a shop intent score was very different for patients treated late, like this one, or patients treated earlier and high functioning, like these 2 who were actually pre-symptomatic patients. So after this initial start study, there was several trials, one in type 2 that has been stopped for safety reason. One large study in type 1 in the US, one in Europe, and a pre-symptomatic trial. So let's have a look. That's these large studies in US and Europe, so they are called STRIVE, and that's the comparison of these two studies in terms of survival and the sad natural history in these patients. So really, these patients are surviving much better, and this is a very large international studies. That's for the American patients, how they are doing in terms of motor function, the sharp intent. And as you might see, it partially reproduces the data that were published in the New England Journal of Medicine, with one more time patients treated early who are doing better. And this is for Europe, and these patients in Europe also to a certain extent reproduce the findings from the New England Journal of Medicine. So let me talk you about two of my patients. And I think that it's an interesting story because they are born at the same time, but they were born in two different countries. Let's call them Jack and John. John was born in December in France, and Jack was born in February, a little bit later, in Belgium. Both have been treated with gene therapy. John, which is the French patient, is here. And that's this gentleman 1 year after the injection. He's a happy kid. He is doing better. He has survived. He has a prophylactic non-invasive ventilation. He's a painter. John is a painter. Obviously, it's not normal. Obviously, he doesn't walk. And this patient was improving, who's still alive, will never be normal, even if he's doing much, much better. He has acquired a sitting position, and he has, as you can see, a very good upper limb function. He can manipulate his toys and small objects, bring it to his mouth, and being able to eat by himself. And this is Jack. Jack live in northern Belgium, where there's no newborn screening, but by chance, the parents, the mother delivered in southern Belgium, and he could be screened, identified by newborn screening. And that's Jack. When I met him, he was completely pre-symptomatic. And the reason why he has an IV line and he is in the intensive care unit is that he's going to receive his fix of Zolgensma. And that's the same guy 13 months later. And as you can see, he's now walking. He can walk front side, back side. And I really hope that the parents will secure the garden, because otherwise, on top of being able to walk, he will need to learn how to swim. So there is no matter of comparison between John and Jack. For Jack, the question is my patient completely normal? And that's the questions that I have today each time I see one of my pre-symptomatic patients. And does my patient present any sign of active innervation that should prompt maybe another treatment? And that's the question that we ask ourselves when we meet this kind of patients. And for post-symptomatic patients, the question is, how proactive should I be on ventilation and pulmonary care? How proactive should I be on bone health? Does my patient swallow really, really well? So one more time, the same drug, the same disease, but if we want to treating pre-symptom is much more efficient. Then I just want to give some words about STRONG. STRONG is an intrathecal therapy using gene therapy. 3 groups of patients have been included, and no safety concern came from human beings, but safety concern came from the monkeys with dorsal root ganglia damage. And because of that, the trial was put on hold. The data that we have so far are quite encouraging, but especially for young patients. And as you might see, that's patients who have been treated before the age of 4 years who get much better results than patients who have been treated later on. And then there is a third approach, which is oral therapy. And oral therapy has been initially published in 2014 in Science, and gave rise to a very large and comprehensive program in type 1, type 2. And type 1 was initially an open label on a limited number of patients, and a confirmatory trial in a larger group. So it was the study called Firefish in type 1, Firefish part 1 and Firefish part 2. In Firefish part 1, one of the questions was, what was the good dose? And for Sunfish was for type 2 or 3. It was initially an open label trial, so with no placebo. And we tried to find the dose, and then it was an open label extension. And during this time, there was a double-blind randomized placebo-controlled study in a very large and very broad population. So the first results, that's the results from part 1. The patients were very old when they were included. They were 6 months and 3 as a median age. And I think that you have understood since the beginning of my talk that if we want to compare the data of the studies, we cannot compare apple and oranges. We need to be sure that we speak about the same kind of patients. So these are quite old patients. Nevertheless, this event-free survival at 12 months was 90%. So 90% of these patients were living without permanent ventilations. And in the second cohort of patients, so the patients were treated with the high dose, 41 of patients acquire the sitting position. This is a patient of the trial, and yeah, she has a very stable position, and this little princess will grow up, and we have in these studies 2 standards. So there was behind the study a study called Firefish Part 2, and Firefish Part 2 included a larger number of patients, 41 patients, and it confirmed the data from Firefish Part 1 with a very high percentage of patients alive, ventilation free, and very interestingly, a high proportion of patients able to swallow and able to be fed orally, which is something that I'm not used to in my cohort of patients with type 1 treated with intrathecal therapy. Then come the data that we have in patients with type 2 and 3. We used another scale, which is MFM32. And in part 1, we first follow a large cohort of patients who had exactly the same inclusion criteria than in Sunfish. And this is this large cohort of patients, and we follow them on 1 year. So as you may see, over 1 year for these different patients, most of them are in a corridor between -3 and +3. So they are pretty stable, and very few patients improve by more than 3 points. And then we had this open label study, and that's patients from the open label studies. And as you might see, many of them are scoring above 3 points. Then came a double-blind randomized placebo-controlled study, because you cannot rule out, of course, a placebo effect if you don't conduct this kind of study. And very interestingly, this study was conducted in patients from 2 to 25 years, so a very large population. And after 12 months, these patients were as an average 9 years when we included them. So the median age of inclusion was actually higher than the oldest patient in the nusinersen trial. So very important to understand that this is two different population of patients who have been treated by nusinersen and the one with oral therapy. So in this double-blind randomized placebo-controlled study, we had a mild placebo effect in untreated patients, but this placebo effect disappeared, and after 1 year, there is a significant difference between treated and untreated patients. And one more time, the difference is very clear in young patients and much smaller in older patients. Interestingly, a scale that assesses the independence of patients demonstrates a significant change in the overall group of patients. To be complete, there is another oral drug that is in development with in the trial has been conducted partially in Russia that shows, let's say, pretty similar data. So now let's start dreaming. You probably have seen this video a couple of times. This is a brotherhood. This little princess has been treated before the symptoms, and we knew that she was affected because of her brother who had been treated far after the symptoms, which I think 8 months after the first injection. This little princess is normal, and this little boy is doing better. He has now acquired a sitting position, but unfortunately, he will never be able to walk. They've grown up, and that's how they are today. That's 4 years later. This girl is completely normal. She brings her brother in a pinky princess room. And I like this video because outside the fact that it shows really the difference between between two patients with the same disease, but one who has been treated after the symptoms and the other one before the symptoms, it shows that pre-symptomatic patients actually help post-symptomatic patients. It's not to treat the pre-symptomatic and not to treat the post-symptomatic. We have to treat both. But the time and the energy that the parents do not have to spend on the care of the little girl, they can use it for the boy. And this is the same, and the same is true for the society, the energy, the manpower, the resources that we will avoid to use because we treat before the symptoms could be used for post-symptomatic patients. And if we do not screen, and if we continue to have a lot of patients coming every year who keep being alive, which is good, but who use a lot of resources, wheelchairs, non-invasive ventilation, this will dilute the manpower that we have in rehabilitation, in pneumology. And if we do not screen, it's very likely that the resources that are available for post-symptomatic patients will mechanically decrease because we'll increase the number of patients in need of these resources. Why we screen in Belgium? We have screened so far 105,000 newborns, and 9 cases have been detected and treated. It's pretty simple. It's a PCR reaction, and as you can see, it's very easy to make a cutoff between treated and untreated patients. Of course, there are challenges and there are issues. It's not a genetic test. It's a genetic test. It's not a metabolic test. How to do with carriers, and what is the predictive values of SMN2 copies. And this is not that clear. One of the questions, of course, is to treat or not to treat patients with 4 copies. And today, honestly, this is an open question. And then another question is to pay or not to pay. What will be the impact on the cost? It's very likely that the impact will be positive because to detect one patient, we had to screen 10,000 patients. And to screen 10,000 patients costs 30,000 euro. So for 30,000 euro, you use the same drug, but you have a patient with normal rather than in the wheelchair. It's very likely that this helps to save money for the healthcare cost. There are several countries in the world where newborn screening is active, and I know that there is a maternity and some pilot in Moscow. So congratulations for that. That's the different regions in Europe and in the United States where screening became a reality. And I just want to figure out what it means. These are the newborns every year in the UK, because I live in the UK. There are every year 72 newborns with SMA, and I like this because we have to figure out that that's a little human being, right? In absence of treatment, 44 of them will die. 23% of them will be in the wheelchair, and 5 will be walking in the community. If you take these same patients, but you start treating without newborn screening, you'll have much less infants will die. You'll have many more in the wheelchair and some more walking. But then if you have screening, newborn screening, you still will have very severe case for whom you cannot do anything. You will miss some patients because of point mutation and they will be in the wheelchair, but you will have a lot of walkers. And that's the 3 situations actually. The patients without treatment, the patients with the treatment, and the patients with newborn screening. And we have to figure out that behind every single kid with a wheelchair, there are parents who have to provide these patients with a lot of support to go to the hospital, and this can be avoided. And we can help to save resources by having kids running in the community rather than in the wheelchair, and so being able to bring a better help for patients who are today in the wheelchair. And the problem is that in absence of newborn screening, after 20 years, each year we are building a cohort of patients in the wheelchair with non-invasive ventilation, with scoliosis. And these are the sum of patients that we have actually created in the UK after 20 years without newborn screening. If we want to have a kind of broader view about the story of SMA, this is the timeline between the description of SMA, and this is a very important date. It's my retirement, and I would be very happy if at that time SMA is a story of the past, and if my granddaughter is tired of my old stories and will say, come on, this is really a story of the past. So I think that today this is feasible, but this passed through newborn screening and early detection to fill the cemetery of all these lethal diseases that can disappear, like poliomyelitis. Certainly SMA could be the next one. And there are actually many others that could one day disappear if we are able to understand that if we want to be efficient, we must screen at birth and we must treat this disease early. So I just want to finish by giving a huge thank to my team in Belgium, in the UK, in France, and my partners in crimes for newborn screening. I would be more than happy to take any of your questions. Thank you very much for your attention.
Значит, у нас был вопрос. Первый вопрос. После какой инъекции спинразы вы видите улучшение? Dr. Serve, please.
So it depends of which patients we're talking about. If we talk about patients with symptomatic type 1, after two injections of Spinraza, you notice already small progresses. And when the patient comes back for the third, most of the time you see yourself some progresses. And it's very clear when the patients come back for the fourth. If we speak about type 2 patients, then you have to wait much longer. And I would say it's much more like 6 months.
Мгм. А, Следующий вопрос у нас был такой по поводу процедуры введения и периодичности дозировки препарата спинраза. В частности, в инструкции сказано, что после 4-й инъекции вводить спинразу нужно каждые 4 месяца. И есть некоторые вопросы по поводу того, как понимать, 4 месяца – это 120 дней или 4 месяца – это та же календарная дата через 4 месяца?
Нет, я думала, переводчик дублирует. Okay, I'm sorry. Loran, can you hear me now?
I can hear you, yeah,
I'm
but
sorry. Obviously, I
yeah,
had to
no
ask
problem.
this question in English once again. So the question was how to make the Spinraza shots after the 4th shot. So the manual says that the regularity is 4 months. But there is some ambiguity whether as for what 4 months means, whether it is 120 days exactly, or it is the same calendar date like for the 4th day of a certain month and then the 4th day of the certain month and so on. So which is the proper way to do it?
Actually, it's absolutely not a problem because the half-time life drug is very, very long. So it will not change anything, whatever is the way you choose to do. So it means that if you do it, you know, like for every calendar month, which means 122 days, right? Otherwise, it will be 120 days. But honestly, it doesn't change. It doesn't change anything because if you inject a shot of Spinraza today, you will have half of the dose like 6 months later, right? So a single day doesn't make a difference, which means that if injection, it doesn't change at all. So it's definitely not a problem. So you can do the way you prefer, and it doesn't change anything.
Mhm. Thank you very much. And maybe then I'll ask the next question, which is somehow related to what you've just said. Due to lots of regulatory problems in Russia today with access to treatments, there may be delays, and people are very concerned about whether it may be harmful to the patient, and what length of delay is fine, and what length of delay may have what consequences, and so on. And whether if there is a delay in treatment of Spinraza, namely, we'll have to repeat the loading doses or not. Could you comment on that? Я повторю по-русски, я так поняла, что надо мне по-русски, по-английски повторять. Я спросила по поводу задержек в лечении, которые у нас, к сожалению, в России могут случиться в связи с проблемами доступа к препарату. Как долго может такая задержка быть без ущерба для пациента? И если есть задержка в лечении, в введении, то нужно ли повторять загрузочные дозы спинразы?
So actually, you can have a delay of several months. It will probably not make a big. Have a delay of 3 months. It's not going to be a major difference. This being said, I'm not encouraging you to, you know, to make delay. I'm encouraging you to follow the schedule, but your patients will not, you know, be very affected if there is a delay of 1 or 2 months. And an adult or older children, I think that of course the consequences of a delay will not be the same. So I'll tell you that for instance, if you experience a delay of up to 2 months, it's probably not going to be meaningful. Probably after that, there is a risk that you fall below a certain threshold. But you should not panic if for one or another reason you get a delay of 2 months.
So, up to months is okay. То есть до 2 месяцев более или менее нормально.
Well, it's not, you know, the best thing to do, but you certainly not have to make a loading dose again, because otherwise you will, you know, even after 8 months of without injection, you probably still have half of the dose of the drug in your body. So you certainly you certainly do not need to make a loading dose again.
Thank you very much. Следующий вопрос. Если у взрослого стоит конструкция на позвоночнике, но нет специального порта для введения, может ли вводиться препарат выше конструкции или есть какие-то иные варианты? So, there is an adult patient and they have a spinal surgery, but they don't have a port for injection. Is it possible that drug is injected higher than the spinal fusion, or are there any other options?
Yeah, there are several options that have been published about strategy to inject in patients with spinal fusion. So it depends on the type of spinal fusion. It depends of the anatomy of the spinal fusion. But I would, you know, for instance, if a patient comes to me today and tell me, well, you know, I've got a spinal fusion and I would like to start an nursing treatment, especially if it's an adult and that it's not a matter of days, I would definitely discuss about what about just waiting that the oral formulation is available. Isn't it more safe, more easier to wait for the oral medication to be available? And you know, for the last I would say year myself, in adults coming with this request of getting Spinraza despite spinal fusion, I've been discussing with them and say, well, look, probably you should wait until the oral medication is available, and you will probably not lose a lot over 1 year since you are an adult, but you know, you have it's going to be so much safer and so much easier to wait for the oral medication to be available. So that's, you know, what I would say today to a patient with adult and gut spinal fusion.
И я думаю, что этим вопросом доктор Серве уже ответил на вопрос, который у нас был в чате. 35 лет, СМА второго типа, какую терапию лучше добиваться? Я думаю, вы услышали ответ на свой вопрос как раз только что. И, наверное, вслед за этим также вопросом задам вопрос, который, я понимаю, что на него нет единого ответа, но тем не менее мы его получаем очень часто, он очень часто звучит в публикациях в медиа, в социальных сетях, в обсуждениях родителей и взрослых пациентов. Какое лекарство более эффективное?
Can you please translate?
Yeah, sorry, I forgot to do it. I know this might be not correct, medically correct question, and probably you won't have a specific answer for it, but it is very popular. It is largely discussed on social media, in media, and between parents and patients. And the question is, what treatment is most effective? What treatment is more effective? What treatment is better, if we have a choice?
Well, that's the $5 billion questions, right? So I will, of course, this is the reason why the first thing the reason why it's very impossible to answer with a very single sentence this kind of question is that we have no study that have that can compare the two the two drugs one against the other. So which means that this is only indirect comparison. So I would ask a more complex way. I think that all drugs cannot. We've just discussed about spinal fusion and nusinersen. I would say that for a patient with spinal fusion and with probably too old to get gene therapy and too difficult to get Spinraza, probably for this patient, risdiplam is the easiest thing. If you have a patient, pre-symptomatic patients, and he has 3 copies of SMN2, and he has the opportunity to get Zolgensma, maybe he has the opportunity to be, off drug for the rest of his life, maybe. So if the parents are happy to consider gene therapy, probably it's a very good option for these patients. But if the patient has 4 copies of SMN2, is in the label of the European Medical Agency, so he won't be because it's just off-label, right? So I think that there is not a simple answer for all kind of patients, and that's the beauty of medicine, is that at the end of the day, it's not one drug that is better than the others. It's you must really make the best decision for any single patient according to his age, his physical condition, his disease duration, and the comorbidity. So there is not a simple answer.
Mm-hmm. Thank you. So the next question is also maybe a general one, because many people are interested in what consequences and what how effective may the therapy combination be if patients combine, for example, Spinraza with Zolgensma, or Zolgensma with Evrysdi, risdiplam, or whether it makes sense to combine Spinraza with risdiplam. Подскажите, just a moment, I'll translate it into Russian. Я задала вопрос о комбинаторной терапии. Комбинировать разные лекарства, если уже получен укол Золгенсма, имеет ли смысл продолжать Спинразу, и имеет с risdiplamом, или даже, может быть, имеет ли смысл комбинировать Спинразу с risdiplamом и risdi. Yeah, please. Dr. Serve,
so
please.
there is no, actually there is not a single evidence that combining treatment. Some cases of patients who've done it, and when we try to see how they bench patients, how they compare with other patients, honestly, we
Dr. Serve, I'm sorry, we have another technical issue, and the specialist asked me to tell you to turn off the translation option in Zoom. Could you do it?
It's already off.
Он уже выключен. Включить наоборот? На английскую дорожку переключить? No, please turn it on again on the English channel.
Done.
Сделал? Все работает?
Yeah,
please,
I
I'm
can
sorry.
I
Please
can
continue.
hear it, yeah.
Please continue, I'm sorry.
It's done. I turn it off.
Yeah, it's. I believe it's fine now. So could you please continue with your answer?
Yeah, please. No problem. So there is today. So I haven't seen any data even suggesting that there was added value to combine the medications. So I'm quite concerned that if we don't add anything in terms of efficacy, today I think that combining medication should be done only in a strict clinical trial and with a very good follow-up. But I think that it's a nonsense today. I think that combination could be meaningful if we don't target the same, if we don't have the same target. So, for instance, to combine a drug that works on the motor neurons plus a drug that works on the muscle, like an anti-myostatin, right? This could be meaningful. This is still, in clinical trials, in clinical development. There are no evidence at all that combining drugs that works both on motor neurons, both on SMN pathways, could be helpful. So I think that the combination therapy will one day occur, but will be the association of a drug that works on the motor neurons plus a drug that works on the muscle. And be careful of safety. Safety is quite a concern by, trying every possible drug.
Yeah, okay. Я задала вопрос по поводу тех препаратов, которые находятся сейчас в разработке. Кроме тех 3 препаратов патогенетической терапии, которые уже существуют в мире, есть разработки препаратов, которые работают на нервную ткань, мышечную ткань и так далее. Я попросил доктора Серве немножко рассказать нам об этих разработках. Yeah, please.
Okay, so actually can you see me?
Yeah. Hi.
So there is another oral medication that is called branaplam, which closely looks like risdiplam in terms of safety and efficacy profile. And there are also drugs that works on the muscle, which are today in clinical development. And you can work on the muscle at different level. You can work to increase the contraction of the muscle. That's a drug that is called remselteltif, which is developed by a company that is called Cytokinetics. There are drugs that works on muscle mass and muscle trophicity, and that's drugs that are called the anti-myostatin, and they are developed by a company that is called Scholar Rock. And there are drugs that works on the neuromuscular junction. And for instance, it's aminophyrampidine that is developed by GSK. So that's the different drugs that are today in development.
I'm back. From the chat was the following. Может ли ребенок oh no, I should say it in English. So can a child restore their function, their ability to walk on therapy if they have SMA type 3, but they have lost it by the time they start therapy?
There are some reports, if they are treated very early on after the loss of ambulation, there are some reports of kids who had lost the ability to walk and who were treated just after that and who could retrieve it. Not that many, but there are reports.
Also, there's a question on Zolgensma. For patients weighing up to 21 kilos. If there is no such data, when can we expect it?
I think that first, there is no data of safety of Zolgensma in patients more than 30. When do we expect it? Well, I don't have a crystal ball, but I anticipate that in many countries in Europe, patients will ask to get Zolgensma, and even if they are like 15 or 16 or 17 kilo, 20 kilo, and it's very likely that in some countries, physicians will agree to deliver Zolgensma despite the fact that we don't have safety data. So it's very likely that this data will come up, well, let's say, probably in the coming 18 months, because, you know, in some countries, even like Germany, for instance, Zolgensma is currently delivered, and I anticipate that many patients, even with weight up to 20 kilo, will ask for it. So the short answer to your question is about 18 months.
Mhm. There are also some concerns about Zolgensma, that it wears out. And is it possible that we'll have to repeat the treatment after, say, several years?
So it's nobody knows how long the transgene will be expressed, and so far we do not have any indication of any patients who have experienced such kind of you know, wasting of the effect. But it is clear, you know, that it might happen, and the answer to the question is no. We won't be able to re-inject Zolgensma a second time for patients who have received it. So it means that we'll need a backup option. That could be risdiplam, that could be nusinersen in patients who have received initially Zolgensma, and for which it stops working. But we must be clear on the fact that if you speak about a post-symptomatic patients, it's very likely these patients will never be normal. And it's not because Zolgensma stopped working. It's just because this patient got the maximal benefit he could, and there will be no additional benefit because it just has no more motor neurons. You know, there is no drug today that makes new motor neurons appear. So which means that when you have recruited the full set of motor neurons, it's very likely that all drugs will have a kind of ceiling effect. And as I told you several times, there are no patients who have been treated with any of the drug after the symptoms and who are normal today. So it's not because patients reach a ceiling effect that the drug doesn't work, right? The patients in which it could be clear that Zolgensma is not working anymore are the patients who have been treated before the symptoms and who are supposed to be normal. These patients who are supposed to be normal, if they start developing symptoms later on, could be potentially because of the lack of expression, of the long-term expression of the transgene. So I think that the answer to come from the pre-symptomatic patients, because in post-symptomatic patients, what happens is that when parents see that their child reaches a ceiling effect, if he's on nusinersen, they ask you to give him risdiplam or Zolgensma. If he's on risdiplam, they ask you to give him nusinersen. And if he is on Zolgensma, they ask you to give risdiplam. But it's not a matter of getting another drug. It's a matter that simply the patient has reached the maximal benefit he could get from restoring SMN protein.
Work. If you reach the ceiling on Spinraza and you start on risdiplam, that wouldn't work.
Exactly. It's just you know, the fact that you know, you have done with the motor neurons that were surviving, changing medication will not help.
Mm-hmm. Mm-hmm. I see. I'm sorry if you've already covered this issue in your presentation because I missed most of it due to technical issues. But I would like to ask this question. I remember that in early studies of Spinraza, we remember that the results were published of clinical trials. Correct me if I'm wrong, about 40% of patients were listed as non-responders to treatment. But today we see that patients are stabilizing, some of them are improving, and so on. Does this mean that this share of non-responders is decreasing with the length of treatment, or are there still non-responders, patients who decrease and patients who have no effect of Spinraza, and what is their share? Could you comment?
Well, the problem is the definition of a non-responder. Let me tell you a different situation. Let's imagine, for instance, a patient who starts a type 1 patient with and improves beautifully on the motor point of view. And 6 months later, or 1 year later, he gets a pneumonia and he dies. Is he a responder or a non-responder? On a motor point of view, he was doing better, but he died. So we cannot say that it's a success because he died, right? So if you look at him in terms of Kaplan-Meier curves of survival, we'll see, well, you know, they are non-responders because they die, and nobody will tell you that someone who died after treatment is a good responder, even if this patient was doing better, right? But life is much more complex than gaining points on a scale. Then let me tell you another story. During my presentation, I told the story of a teacher who was 49 years old and who lost the ability to paint. If you score these patients using a Hammersmith scale, she scores 0. And then she loses the ability to paint, and she still scores 0. And then you treat her, and she retrieves the ability to paint, and she's still scoring 0 because she's at the floor effect of the scale. But what does it mean? It means that if you look at with the definition that a responder is someone who improves by more than 3 points on the Hammersmith scale, she's a non-responder. She was a stable patient and she's an absolute non-responder, but she's the happiest person about the treatment, and quality of life has improved dramatically after treatment, and she will define herself as an excellent responder. So what do we call a responder? So I think that the problem is that in a clinical trial, you will need to adopt a definition, right? And if you say, I will call a responder someone who has improved by 4 points on the SHOP intent. Personally, I will not call it a responder, because if a patient has a type 1 and he is you know, bedbound and he improves by 4 points on the SHOP intent, it is still someone with a very severe disability who will be a huge burden for himself, for the family, for the society. So if you just keep this patient alive and help him or her to get 4 more points on the SHOP intent, I mean, I'm not sure it's a success at all, right? And on the contrary, a patient with type 2 or type 3 retrieve an ability that was lost, even if it does not translate on any scale, for me is an excellent responder. So I think that the problem is it's just a matter of definition. And so being or not being a responder can be a definition for a trial, but it cannot be a definition for a patient. A patient cannot be, you know, qualified as a responder through a scale. A patient is a responder if he or she reach his or her ambition with the treatment, his or her objective with the treatment. So when I start treating a patient, I start by asking him or her, what do you expect from the treatment? And the painter with wheelchair bound for 49 years who is hardly able to have a pencil in her hands, if she tells me, well, my objective is to jump, I will tell her, well, you know, we should even not start the treatment because you will be disappointed. If this is what for you is meaningful, you want with the treatment, forget about it, do something else. If your objective is to be able to paint again and you've just lost it, then we maybe can reach it. And this is meaningful to start treating. So I think that when it comes to an individual patient, we should not discuss in terms of scales. We should discuss in terms of therapeutic objective. What do you expect from the treatment? And you know, one more time, if it's realistic and you reach it, then you can be defined as a responder.
I have a couple of questions, which are actually maybe more for the medical community. But the reality is that in Russia, parents and patients often have to become partly medical, like amateur medical. And my first question will be about the scales that you just mentioned. Could you give just a brief overview as to what scales do you usually use to evaluate the motor skills in infants, in kids, in adults, because there's a big variety. We know chop and tend, we know Hammersmith, we know upper limb module, and so on. And I understand that this is a question to our doctor, but we unfortunately, as parents and patients, we need to sort such things out sometimes.
Well, I use chop and tend, of course. I use INI. I use MFM, and honestly, I much prefer MFM than Hammersmith because it's much more sensitive. But the real question before using a scale or anything to measure a patient is, why do you do that? Because one more time, if I want to know if my patient responds to the treatment, he or she needs to have objectives, right? So if I use a scale to try to figure out if my patient is responding in the first months because, for instance, he has a spinal fusion and I deliver Spinraza, so I want to be sure that I'm not doing that, you know, just for nothing. So I want to be sure that there is some kind of response. It would be a very good reason to have a scale which is sensitive. Then, if I want to quickly, if my patient is actually a responder, then I will not use a scale. I will try to measure very precisely the strength, and I will try to measure very precisely the activity using wearable technology. So we have, for instance, with my team, created a device that measures any movement of the patients, any activity of the patients, and it is extremely sensitive to change, which means that if a patient with type 2, if we record a patient with type 2 who is not treated, we can measure a decline over a 6 months period. So it's very sensitive to change. So if the question is my patient doing early better so that I can be sure that it's the right thing to do, it's the right things to do, and that I should continue treating him, then I use this kind of technology rather than scales because it's much more sensitive.
Did I understand correctly that it's a kind of like a game?
It's virtual reality. It's a wearable technology. So it's actually like a watch, like you could say an Apple Watch or something like that, but it's much more precise, and it's a medical device, which an Apple Watch is not. So it's it's like an Apple Watch, and it measures any single movement. But you can tell, okay, my patient has moved like, I don't know, 2,533 times, and the movement, you can measure the movement, and you can do it during like, I don't know, 2 months. During 2 months, of course, if the patient has a bad day or a good day, at the end of the day, if you can measure a lot of days, you can have a very precise estimation of the patients, and that's why it's so incredibly sensitive. So that's what I use personally to, if I need something to detect a very early change, in order to be able to say, well, this patient is on the right treatment because he is doing better, even if it has not yet translated into something that I can measure on a scale.
Yeah, sounds great. And one more question, which is more for the doctors, but we also, there are many questions regarding it from the parents and from the patients. And this is about during Spinraza injections. What do you use? What is better? There are some patients who have had no sedation and they were in pain, or others who are, on the other hand, concerned that they had too much of it. So what do you do in these terms?
So first, it depends of the patient, of the age of the patients, of course, because the answer is not the same for a baby or for an adult. And then I would say that as a general rule, there are many things on which we can act sedating the patients. The first thing is that if we do the injection very properly, very quickly, and if we succeed immediately in doing the injections, of course, it's going to be much less painful and much less stressful for the patient. The second thing is that we can make a confident atmosphere, if we can make some fun, if we can, being all relaxed, you will decrease the need of sedation. Then there are several ways to decrease pain without sedating the patient. And for instance, a baby, we used to give him or her some water with sugar, and we put it on the pacifier, and the mother stay with the child and give a hug. And with the hug of the mother and the pacifier with sugars and cream in the back, if you do it quickly and efficiently, and if the mother trusts you and she's not anxious, then it can go very fast and you don't need anything, right? And in all the children, we use meopa, so a gas, that makes people happy and laughing. But of course, if there is a lot of stress and if the child is already crying and you just put the gas on his face, it will not work. So it means that you must work before creating a confident atmosphere and having fun, and then using this gas as a kind of fun, and then the child will accept it and will be, much less anxious during the procedure. But if when you come with the gas, the child is already crying and shooting, it will not help. So I think that it's a very over context. Then in patients for which we cannot do another way, we can use ketamine, and ketamine can be very helpful, especially in the teenagers. And if patients, for instance, have bad trip with ketamine, then we use propofol. So that's the different things that we use. But honestly, we do not need to use so much sedations.
Mm-hmm. And are there any indications for general anesthesia?
Well, general anesthesia, I think really exceptional, really exceptional. It's really for patients very difficult injections, which are super anxious. But if you come to this, then you should discuss with your patients, are you really happy to get your injection? Because if we need to go for a general anesthesia, I mean, why? I mean, if you don't want your injection, maybe the best thing to do is not to get it, right? So I think that for these patients, I would certainly argue, is it really a good idea to continue the treatment, or should you wait for an oral medication?
Yeah, sometimes I think this is for the anxiety, not of the patient, but of the doctor who has to do it for the first time.
So honestly, I'm not sure I have a single patient with general anesthesia.
Yeah, I see. Я хочу обратиться к нашей аудитории. У нас осталось буквально пара минут с доктором Серве. Если у вас есть еще какие-то вопросы, пожалуйста, напишите их в чат, мы успеем на них ответить, потому что у меня вот остался последний вопрос сейчас в списке. So the next question is, probably the last question. As I've just said, this is my last question on the list, and if while we are discussing it, something comes up on the chat, then I'll ask one more question. But as for now, this is the last. So the question is about the choice between risdiplam and Spinraza, which I can say is common choice today in Russia already, because there is an open access program on risdiplam, and Spinraza is a registered drug, which is, I would say, partly available through the public health system. And people have this choice, and it targets the same target as SMN2. And so the question is from a parent of a child with SMA type 2, whether there is a preference, what would be better to start on for this child, Spinraza or risdiplam?
Well, you know, it depends one more time of the age of the patient and let's imagine that the patient is 12 years old and has a spinal fusion. I would say probably the easiest is to go with the oral medication, right? As I told you, we don't have a back-to-back comparison for these patients. So it's very difficult for me to tell you, you should go for this one or that one. I think that I would consider things more on the injections, on the route of administration. What is the most convenient for this child? Is it the oral or the intrathecal? And because you may also have child who refuse to drink the syrup, or who are not cooperative. This could be a reason to go for intrathecal. And then also to try to discuss with parents what I mean, let's imagine that both drugs are equally efficient, which is possible. I mean, are you more confident with the drugs that has been used, you know, in 10,000 patients across the world, for which now we have 5 or 6 years of follow-up? Or are you happy to go with the drugs for which we don't have any safety concern today, because there is no safety concern for risdiplam, but we certainly not have the same amount of patients who have been treated and the same disease duration. So on the other hand, if you consider all the patients, there is no very strong signal of efficacy in patients with type 2 who are older with nusinersen, but we have data of efficacy in patients using risdiplam. So that's all the points I would consider. So I'm sorry, again, not to give you a very clear answer like, okay, guys, you should go for that drug or this drug. But I think that if I would do it, I want to be very honest, because we do not have the data in our hands to answer today. So I think the best way to answer is this must be an individual decision based on the profile of the patients, his understanding of the risk, and the age of the patients, the availability of these drugs. And so this is something that must really be discussed on a case-to-case basis. And unfortunately, I do not have a, an answer that can be applicable to all patients.
Mm-hmm. So I think that was the last question, but I would, while you were answering it, I had another one that came up about risdiplam. We know, I think that today in Russia, we know more about Spinraza already, since it has longer been on the market, and we've had more experience with it. But speaking about risdiplam, we haven't had a lot of knowledge about it. Could you please tell us about any side effects or any, because we know that with Spinraza, there's this huge risk and concern, maybe more concern than risk, but anyway, about this spinal injection. But with risdiplam, it means like it's totally fine. It's an oral drug, it's a syrup. They say it tastes not that bad. So what might be the concerns about risdiplam? Are there any side effects? Are there any effects on the gastrointestinal system or anything? Or allergies maybe?
Yeah, so today there is no, side effect that came from the trials that was completely different between patients who were on placebo or patients who were on risdiplam. You must know that during a trial, we used to collect everything that happens, and until the contrary is proved, we can consider that anything that happens may be due to the treatment. So far, it's as stupid as if the patient has a car accident, we notice that and we consider it can be a serious adverse event if the patient is hospitalized, but it's because the patient is hospitalized because of the car accident, not because of the medication. So if we want to know, the only things we can do is to compare with patients during the same period of time who have received a placebo. And when we do it, actually there is nothing that we find more frequently in patients on risdiplam in comparison with patients on placebo, which is super reassuring. So far there is no real clear adverse event, but we must be cautious because it's still a limited number of patients, first thing first. And the second is that we don't have years of follow-up. So what will happen in 5 years? What will happen in 10 years? What will happen when we'll have 10,000 patients treated? Nobody knows. And so I think that we still need to be very cautious. In the monkeys, so in the non-human primates on which there was some safety data, there was a concern about ophthalmological toxicity, but this has never been found in humans. So in humans, it has not been observed. So the clear answer is today, no concern, but let's remind that we don't have a lot of experience yet.
Mm-hmm. Mm-hmm. Thank you very much. We have one more question, and I must be honest, I don't completely understand it, but I will ask it as it is. So maybe you can comment on it. What is the difference between genetic SMA and non-genetic SMA, and is there any difference in their treatment?
Well, spinal muscular atrophy can be caused by several genes. And the most frequent is spinal muscular atrophy caused by the lack of SMN protein and a mutation of the SMN gene. But there are many other causes of spinal muscular atrophy by other genes. They are all super rare, and we don't speak so much about it, but they exist, right? For this form of spinal muscular atrophy, we do not have treatment today. That's as easy as it is. So we have treatments only for spinal muscular atrophy that is related to SMN gene. So that's my understanding of the question.
Mm-hmm. Dr. Serve, thank you very much. I think, can you hear me?
Yes, I can hear you.
Yeah, so I think that's all we have for today. Thank you very much for your information and also your patience about our technical issues. I think we've learned a lot today from you. Thank you very much.